Okay, so tonight we're going to talk about schizophrenia, which I think is one of our more interesting lectures that we talk about. So schizophrenia is a disease that causes individuals to have strange, bizarre, distorted thoughts. Their perceptions are also bizarre, the way they perceive things to be. Their emotions, even it can affect their movements and their behavior. We do not consider schizophrenia as a single illness. It's thought of more as like a syndrome that has a lot of other different varieties and symptoms, kind of like how we think about cancer. Many used to believe that people with schizophrenia needed to be locked away from society, and they believed that the only acceptable place for them was to be institutionalized. And that's how it was years ago for many, 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 many years. But we saw in mental health, we had that big switch to really building up the community and doing more for these individuals that suffer with mental health so that they can be productive members of society. And patients that have schizophrenia, it's no different. The same has been done for them. So through the extensive education that we've provided to the community and those newer atypical antipsychotic drugs, we have many, many, many people that suffer with this disease but are living successfully in the community. Usually a person is diagnosed with schizophrenia earlier in their older adulthood. So we say late adolescence to early adulthood. The peak age is 15 to 25 for men, and for women, it can be 25 to 35. So this is definitely something that we see in our younger population. It is estimated that about 1% of the total population has schizophrenia, and in the United States, nearly 3 million people are, have been, or will be affected by this disease. Oops. Okay, so when we talk about the symptoms that patients have from schizophrenia, we divide them into two categories. So one is positive, or they call hard symptoms. The other one is negative or soft symptoms. So, and we're going to talk a little bit more in depth about these, but our positive symptoms or our hard symptoms, these include their delusions, the hallucinations. They have a very disorganized thinking process. Their speech is also disorganized, as well as their behavior. When we look at our negative or our soft symptoms, this is going to be how they present to us. So they might have a flat affect. They might have a lack of volition, social withdrawal, or discomfort. Negative symptoms over time present with a major barrier to these patients being able to be productive members of society and gain that improved functioning. We do know that medication can control the positive symptoms, but frequently what we see is that those negative symptoms will persist long after the positive symptoms have stopped or they're being managed. So it's really those negative symptoms that really cause them to not be able to function like they should be. So when we talk about these positive symptoms, these are all the positive symptoms. So they have ambivalence, which is, and you guys need to know these, this is when they are holding a contradictory belief or a feeling about some type of a person. It could even be an event or just some type of situation. They also suffer with associative looseness, which is fragmented or poorly related thoughts and ideas. So it's going to be really hard for them if you're having a conversation. The things that they try and tell you about are just going to come out in pieces. It's going to be fragmented. Then we know these delusions, which is one of the biggest things we see, the delusions and hallucinations. So these delusions are fixed false beliefs that have no basis in reality. We have something called echopraxia. This is the limitation of the movements and gestures of another person whom the imitation, I'm sorry, I need my glasses. It's the imitation of movements and gestures of another person whom the client is observing. So if you're sitting in this facility, or if you live in this group home with this person and you you have certain characteristics that you do. So if you talk all the time with your hands like I do, or if you say a certain thing all the time, these people will actually start to mimic your characteristics and the things that you say. Flight of ideas. This is a continuous flow of verbalization in which the person jumps rapidly from one topic to another. So they really don't speak in complete sentences. Their conversations don't really flow. And then we have hallucinations, which is the other big one. So these are false sensory perceptions or perceptual experiences that do not exist in reality. The thing about hallucinations with these people is usually very early on in the beginning stages or the first couple years of them being diagnosed. To them, these hallucinations are very, very real. They don't know that they're not real. As they progress through treatment and they get different medications and more counseling, they will be able to at some point recognize them as hallucinations, and they won't act upon them, and they won't get so upset over them. Ideas of reference. This is false impressions that external events have special meaning for the person. Perseveration is the persistent adherence to a single idea or a topic, verbal repetition of a sentence, a word, or a phrase, and resisting attempts to change the topic. So no matter how much you try and take their mind off of one thing, they're just going to keep talking about it over and over and over again. It's not going to be easy to distract them. And then bizarre behavior, they can have an outlandish appearance or dress a certain way. It can be repetitive or stereotyped. They may make movements that don't seem to have a lot of purpose to them, and they may have unusual social or sexual behavior. So these patients will dress very, not all of them, but some of them will be very, very bizarre. So it might be the middle of summer and they might be running around in a full winter coat with boots and hat and gloves. So something that's really not appropriate. Then we have the negative symptoms. So you should also know these. So alogia is a tendency to speak little or to convey little substance of meaning. So they don't give you a lot when they're talking. So it's kind of like you feel like you're pulling teeth to try and get information from them. Anhedonia, this is feeling no joy or pleasure from life or any activities or relationships. So these patients don't really ever express an interest in things like, you know, I've had a really bad week, but I really love when I get to do this. They don't really express any type of pleasure with anything at all. Nothing really brings them joy. And they all are kind of always, people kind of think of them as always being negative because they don't ever talk about really any positive things because they don't ever see positivity in their life. Apathy, which is feelings of indifference towards people, activities, and events. Asociality is social withdrawal. So they won't have very many friends. They won't have a lot of relationships, not even with family members. They don't ever get that closeness with anyone at all. They have this blunted affect. So it's a very restricted range of emotional feeling, tone, or mood. Catatonia, which is physiologically induced immobility, occasionally marked by periods of agitation or excitement. So the client seems motionless as if in a trance. So you could just be sitting there talking to them 1 minute and then the next minute they've completely zoned out. They don't move at all. Their eyes don't blink. Some people think that they're actually getting ready to have a seizure when it happens. Then flat affect, we know what that is. That's the absence of any facial expressions that would indicate any type of emotions or mood. Avolition or lack of volition is the absence of will, ambition, or the drive to take action to accomplish tasks. And then inattention. So this is just the inability of them to be able to concentrate on you if you're having a conversation. They can't really stay on topic when they're talking. They can't sit with an activity for a certain period of time. You'll notice that in these, if you ever see them in the outpatient setting for like a clinical or something, they often move from table to table, person to person, game to game. They can't really sit for any long period of time. It's hard to hold their attention. So the etiology of schizophrenia. So there is it does have a genetic component, but there's no specific gene that through research they've ever been able to find to say that this is the gene that causes schizophrenia in patients. They actually believe that it's polygenic, which means that there's a couple different genes that actually contribute to the development. They don't know exactly which genes they are, but they do believe that there's a couple of them that do it. It's still very highly researched. There is a risk that if one parent has it, then the child has a 15% risk of developing it. If both of the parents have schizophrenia, then there's a 35% risk that that child will have it. But with identical twins, that percentage goes up by 50%. So if you're an identical twin, even with fraternal twins, it's not the same. I think it's like I don't know, like a 19 or 20% chance if you're a fraternal twin. But if you're an identical twin, then that risk goes up to 50%. There are some neurochemical things that contribute to the development of schizophrenia. So one is serotonin, and then one is dopamine. So they believe that the serotonin modulates and helps control the excess dopamine in the body. And some researchers believe that that excess serotonin contributes to the development of schizophrenia. And then the other development is that they believe that there are drugs that increase the dopaminergic system that can induce what they call a paranoid psychosis reaction similar to that we see in schizophrenia. And what happens is it blocks the postsynaptic dopamine receptors, which reduces the psychotic symptoms. So we have learned that patients that have schizophrenia suffer from immunovirologic factors and structural abnormalities. So with structural abnormalities, on X-rays and MRIs, these patients have enlarged ventricles and less brain tissue and cerebral spinal fluid compared to people who don't have schizophrenia. They also have a decreased brain volume and abnormal brain function in the frontal and temporal lobes. And they also have different alterations in their neurotransmitter systems. The immunovirologic factors, they believe that at some point in time, they could have had an exposure to a virus, or the body's immune response to a virus could have altered the brain physiology, which then in turn causes this schizophrenia. And then there's also another belief that these cytokines also play a role by signaling the brain to produce certain behavioral and neurochemical changes that then manifest into schizophrenia. So typically the course of illness, usually the onset is very abrupt. It happens very quickly, like one day these patients are fine, and then the next day they start seeing side effects of this disease. So abrupt onset, but after that, they have kind of like a gradual development of signs and symptoms. So at first, it's very hard to diagnose because they can write it off as other things. But then as time goes on, they start to see this gradual development of all these other signs and symptoms. Some of the things that we see at first, and remember some of these we're seeing because of their age group, right? 15 to like 35, depending on what sex you are. So we're going to see social withdrawal in school. They're not going out for sports. They're not really doing those extracurricular activities. They don't have a lot of friends to hang out with. Maybe some type of unusual behavior that's not really common to that child. Loss of interest in school or work. So they might not be doing well at work. They might not be working. They might not be doing well at school. And then also neglected hygiene. So not showering, not brushing your teeth. But a lot of these things are just your normal teenagers. You know, I mean, 3 of those things I can say is my son. You know, he doesn't want to go to school. He complains about going to work, and he has a girlfriend now, but I always used to have to tell him, take a shower, brush your teeth. So these are the symptoms that are easy for people to just kind of brush off and might not really notice that it's something like schizophrenia. So the diagnosis usually is with more active presentation of those positive symptoms that we saw of psychosis. So it's going to be those delusions, the hallucinations, and then that really prominent disorganized thinking and behavior. So there's an immediate term course and then a long-term course. So immediately, we're going to see two different patterns. They're going to have this ongoing psychosis and they're never, ever going to fully recover. That's one path. The other one is that they will have episodes of psychotic symptoms that alternate with episodes of relatively complete recovery. So almost like a remission state. So when they are in remission, they're going to be highly functioning. They're going to be able to participate in society. They're going to go to work, be able to live on their own. And then they just have these intermittent episodes. So that's the immediate term course. Long term is going to be that the intensity of psychosis diminishes with age as they get older. They will have difficulty functioning in a community setting. So really being able to be responsible for themselves, pay bills, have a checking account, drive cars, keep a job. A few of them will be able to live fully independent lives if they get a medication that works and they have that episode where they just have these kind of like breakdowns, every so often, but relatively they're in this remission. Those are the people that we see that can really live good independent lives. And then as always, we know that these antipsychotic medications are crucial for patients that have this disease. So finding one that works, that doesn't have all the side effects is crucial in determining the outcome of these patients and how successful they're going to be in the community. There's also something called schizoaffective disorder. This is diagnosed when the client is usually severely ill and has a mixture of psychotic symptoms like we see with the schizophrenia, but also mood symptoms. So it's a mixture of both psychotic and mood symptoms. So signs and symptoms include those that we would see with schizophrenia and a mood disorder such as depression or bipolar disorder. Symptoms can occur together or they can alternate between psychotic outbreaks and then these mood disorder outbreaks. Treatment for schizoaffective disorder will target both symptoms, so the psychotic piece and those mood symptoms. So you're going to have your antipsychotics and then probably some depressant or anxiety medicine as well. Symptoms present for at least 2 weeks usually when they're having kind of like an outburst or like an attack. The prognosis is better than for patients who just suffer from schizophrenia. And then for this particular disorder, we have found through research that those second-generation antipsychotics are the best first choice for treatment. They work the best. And then we said that these patients may need a mood stabilizer or an antidepressant because of that, because of the mood symptoms that we see. So like with everything else, there's always cultural considerations. So certain ideas might be considered delusional in one culture, but could be completely acceptable in another culture, such as the belief in sorcery or witchcraft. So that's something big to think about. These auditory or visual hallucinations could be part of a normal religious experience in some cultures. So some people saying that they've seen the Virgin Mary or hearing God's voice. Something else you have to take into consideration when you're dealing with these patients. There are certain cultural bound syndromes. So I named a couple here. You guys can go in and look in your book. It goes into a big detail about all of them on page 259. So there are psychotic behaviors that are just observed in countries other than the United States that we find predominantly with certain ethnic groups. So the Buffy Delirante is one, the ghost sickness and the Lacora. But please go to page 259 and read them in your book. There are also ethnic differences that cause a different response to psychotropic medications. So because of our genes and our chemical makeup, the way we respond to these medications is going to be different. So the difference in response is probably the result, obviously, of the person's genetic makeup. Some people metabolize certain drugs more slowly, so the drug level in the bloodstream is higher than desired. So just a couple of things to think about. So with these patients, when we do that physical assessment, we really need to know a lot about their past medical history. So do they have a previous history with schizophrenia? We want to know this because we want to see how well they're functioning now, and we want to be able to determine some type of a baseline. If they have been diagnosed with schizophrenia, we want to know what is the age of onset, because we know the earlier age of onset equates to a poorer outcome. Have they had any previous or recent hospitalization admissions? So that's going to tell you a lot about how functioning they are in the community and how well their disease process is being managed. If they tell you that they've been in the hospital, 8 times this past year and it's only June, then they're probably not doing very well on their own. We want to know their current support systems. So these people need a lot of support through their family and friends. Some of them have isolated these people depending on their behaviors. Some people have a great support system. So we want them to have the best possible outcome. So we need to know who they have in their life to support them that they can really lean on. And then we want to obviously know the client's perception of his or her current situation. So do they feel like things are out of control? Do they feel like they're living their best life? What do they think? Because that's really important. That's going to determine how we treat them and what we focus on. So again, family history and relationships. Do they have a good support system? Does anyone in their family history have schizophrenia or any other mental health diseases? Do they have any substance use or abuse issues of their own? Psychiatric history other than the schizophrenia. So were they diagnosed with depression at some point, anxiety? We could look at any labs that they had drawn recently, particularly probably like to medications that they were taking, therapeutic levels, things like that. And then depending on if it was warranted or not, we might want to do a mental status exam on them. Okay. So when we are doing that assessment and we're looking at their appearance and their behaviors, so are they displaying disorganized behaviors? Are they just all over the place? Do they appear agitated? Are they clenching their fists? Are they doing non-purposeful movements that don't really make any sense, or just any random movements, like in the middle of talking? Are they just raising their hand up for no reason? When they're sitting, are they sitting in the chair comfortably, having a good conversation? Are they all curled up in a ball? Are they sitting Indian style? Are they holding themselves in a ball? How are they postured? Do they have what's called waxy flexibility, which is where they will curl up and they'll stay in one position for a long period of time? Most often than not, you'll see them curled up in a ball in a corner somewhere or in their chair, and they will stay there forever. They won't budge. Then we have that echopraxia, which is where they're imitating the movements of someone that they are observing or someone that they know. So you might see, this could be the first time that you saw them and you're talking to them. And like I said, maybe you're using your hands a lot. Well, you'll notice that they're paying attention to you and your hands, and then they'll start doing the same thing. Are they restless and unable to sit still? Do they appear agitated and pacing? Are they moving from their chair, walking around the room? Do they have any type of psychomotor retardation? So are they very slow when they're walking? Any type of ritualistic or stereotypical movements, like they might walk around, look like they're sweeping the floor, but there's really no broom in their hand? Or are they in that catatonic state that we talked about, where they're not moving at all, like they're frozen in time? And then again, we said their appearance, they could be very disheveled. Their clothes could be dirty. Their clothes can be mixed match. They might have different socks on, different shoes, no shoes. They could be dirty, very poor hygiene. Their hair's not done or hasn't been combed or cut. They might have a lot of facial hair. And then again, that inappropriate clothing. So is it summertime and they're wearing a winter coat and a hat? Or is it just the opposite? It's wintertime and they came in their bikini. So these are the behaviors that you would see. They also can exhibit unusual speech pattern. So a couple of the things we might see neologism. So this is where the patient invents their own words. They just completely make them up. They're not they're not normal words that you and I would know. So for example, the patient could say, the statutorians are poisoning my mind. Well, there's no such thing as a statutorian. It's not a real word, but in their world, it is. Then we can have something called word salad. So these are jumbled words and phrases that are disconnected and incoherent. They don't make any sense at all to the listener. So frames, wolves, candles, what, death, sandwich, they'll say them in a sentence form, but none of them relate to each other. Then we have clang associations. This is where the patient speaks in rhymes. Echolalia, which is the repetition or imitation of what someone else says. So this is when the patient, I cannot talk tonight, the patient mimics the words that the staff or patients say to them. So you could say, Robert, it's time for you to take your medicine. And then he'll look back at you and say, Robert, it's time for you to take your medicine. Or, come on, Robert, we're not going to do that task anymore. And then he'll walk behind you and say, come on, Robert, we're not going to do that task anymore. It's really creepy at first. Like, I don't want to say that like in a disrespectful way, but it does catch you off guard when you see it. And it is a little bit strange for sure. And then we might see latency of speech due to their thoughts. So sometimes they will have a very long hesitation before they answer you. And asking them over and over again is not going to make them answer you any sooner. So sometimes they really have to work through the thoughts that they have in their mind. And it could be the thoughts that they hear, like other voices that are talking to them, which can be very challenging for them because they can't think of what you're asking them if they hear voices of someone else talking. Or sometimes it's just that latency. They really have to take the time, and you can see them thinking about it. So you just kind of want to give them the time to really be able to finish that thought and be able to answer your questions. And then sometimes they may speak in whispers or hushed tones, and they don't, or they can be the complete opposite and they can talk very loudly or yell. So these hallucinations and these delusions, these are two of the things that are the most predominant things that we see in patients that have schizophrenia. So this subjective sensory experience that they experience, it's not caused by any external stimuli at all. They have a false sensory perception, or their perceptual experiences that do not exist in reality. So they're seeing things that are not really there. It can evolve in any of the five senses or bodily sensations that we have. It can be very threatening and frightening to the client. And like I said, initially the patient perceives it as real. Later in the illness, they start to recognize them as hallucinations, but they're still there. And they might still talk to people, but they do know that they're not going to be as concerned with them anymore. They're not going to feel threatened, and they're not going to be scared. So when they start to see between this and the delusions, these seem very real to them. So then they start to act accordingly. So if they're seeing something that is threatening them, then they're going to present in a threatening manner, or they're going to try and defend themselves. The same things with the delusions. So the delusions are fixed false beliefs with no basis in reality. The paranoid is probably the most common that we see. They think someone's trying to hurt them. They think someone's trying to kill them. Someone's poisoning their food. Somebody's out to get them. There is this huge sense of external control. So the client believes that the delusion that he or she sees is real, so therefore they act accordingly. And if you go to box 16.4 in your book, you can see the list of the types of delusion. Can somebody?
It's Nicole.
Mute?
Miss David, I don't know if you like if you hop over that over the mic, you should be able to
Nicole,
Nicole.
All right, I think I just muted her. I had to find her, but I did. I think I muted her. I did. Okay. All right, so continuing on with our assessment, when we're looking at their judgment is almost always impaired, obviously. They have a very poor connection to reality. Their insight is impaired, especially early on in their illness, when the client, the family, and the friends also do not understand what is happening. Their insight is impaired because everything that they see is so real to them, and it's hard for them to really kind of make sense of it and understand that they have a mental illness and that these things aren't really happening. Sometimes their lack of judgment can be so severe that they are not even capable of meeting their everyday needs. So just keeping themselves safe, keeping themselves out of harm's way, like being able to cross the street with and know to stop at the crosswalk, or just know to look both directions to make sure there's no cars. Failing to recognize when they're sick, if they have a fever, knowing when they should go to the doctors and things like that. Also with recognizing the need for sleep. So sometimes due to paranoia and their persistence, they will stay up all night to avoid certain things if they think something's going to hurt them when they're asleep. So really not being able to even recognize the need to have sleep to be healthy, because we know sleep deprivation can actually kill us. So they won't ever be able to put those two together, and they'll go without food for a long time if they think someone's poisoning their food. So they have a huge lack of judgment. And then their self-concept, well, obviously they have issues with that. So, it continues to deteriorate their self-concept throughout this disease as it progresses. It's a major problem for them. They have a lack of ego boundaries. So they suffer from depersonalization, derealization, which is where their objects that are in their environment become smaller or larger, or they become unfamiliar altogether. They don't even recognize certain things. And they experience what's called ideas of reference. They fail to recognize their body as their own, so they don't even realize that they are who they are anymore. And when they do talk, they'll talk in third person. Like if you say, "Come on, Robert, it's time to go take your medicine." Well, Robert doesn't want to take his medicine right now. Robert's not here. He'll be back. He's going to have lunch. This is how they will refer. They won't even recognize that they are Robert anymore. All right, so roles and relationships. This is a very hard issue for most of these patients. So mainly because they experience these delusions and hallucinations, for strangers, they don't want to be around them because it can be very frightening and upsetting when you see someone that is acting out and talking to someone who is not there. So it's hard for them to make friends and keep friends. And then it also takes a toll on their relationships that they have with their family members because of their erratic behavior and the way they behave. It can be very overwhelming for their families. They also develop this lack of confidence, obviously, because, people are not kind. So I'm sure at some point in these times when they are exhibiting delusions and hallucinations, people have probably said very mean things to them. So then they develop this lack of confidence. They cannot relate to themselves anymore. They have major issues with trust. A big part of that is the paranoia that they have, but they don't feel like they can be intimate with people, and they don't trust them. Very low self-esteem, they lack confidence, and they obviously feel different from other people because, as they get older and they realize that these hallucinations are not real anymore, they still feel like they're always different. And they don't want to be put in that situation that makes them feel bad about themselves or embarrass them. So that leads to them just avoiding people altogether. It can be very, very hard for them to fulfill the shoes or the expectations of their family members. So their family members obviously want the best for them. They want them to be successful, live in communities, take their medications. it can be hard for them to manage their disease and be what they are expected to be for their community if they're living in a group home or if they are involved with their family members. It can be very hard for them to be responsible and be productive at work and school because of all the issues and the side effects that they deal with from this disease. And let's be realistic, if you don't really see people that work at Target walking around having delusions and talking to themselves, so it's hard for them to find jobs. They're very limited in places where they can become employed, so that's another issue. And then being able to just pay bills, have a bank account. They can't remember things. They can't pay attention to things. They can't think clearly, especially if they're having delusions and hallucinations. It's it's a very overwhelming disease for sure. So some of the nursing diagnosis that we may see: risk for other directed violence, risk for suicide, disturbed sensory perception, disturbed personal identity, impaired verbal communications. And then if we were to develop a nursing diagnosis and a plan, an example would be disturbed sensory perception evidenced by auditory hallucinations. So a short-term measurable goal would be that they will state, using a scale on 1 to 10, that the voices are less disturbing or less distracting within 72 hours. That's a great outcome. And then long-term goal, the patient will demonstrate tasks that distract themselves from the hallucinations within 2 weeks. So when these patients are having these auditory hallucinations, we need to know how to support them and help them. And freaking out is not how we respond to these people. And so there's a whole self-awareness part of this that you guys have to be aware of as well, probably more so in this situation than in probably any of the other ones that we've talked about, because these can be extremely scary and frightening. I remember back when I did mental health and I went into the Masonic home, and it was like a group home where they went during the day. They lived across the street in a group home, but they would come to this outpatient center during the day. And there was only like 8 of them. But I'm telling you, it was just very bizarre. It made me feel uncomfortable. I was scared when the people started talking. I remember this one guy who used to talk in third person, and he would talk very low. And he would walk behind me. Every week when I was there, he liked me for whatever reason. I attract all the best people. And he would follow me around, and he would say, I can't remember what his name was, but he would say, Robert is behind you. Robert is following you. Robert likes you. So it's okay if that makes you feel some sort of way, or you don't feel comfortable for that, then mental health nursing is probably not the nursing for you. The important thing is that you realize that that's probably not your specialty and you don't like the way it makes you feel. But if you guys do wind up getting into some type of clinical this semester, which I don't think it's going to happen, but if you do happen to get a day or two where you get to go, and you have someone who's doing these auditory hallucinations, this is how we want to handle them. So we always want to make sure that we're being very observant when we are in that milieu with other people. We always need to keep an eye on them, see how they're intermingling with each other, watch how they're moving, what are they doing, and we want to make sure that that environment is always safe. Too much stimuli for these people can cause an exacerbation of their symptoms. So we want to reduce their stimuli as much as possible. So you'll see in the outpatient environment that it's kind of broken up, where they will have they might have an exercise group where everybody does exercise together for maybe 30 minutes, maybe 20 minutes. And then after that, they break up and they go into groups on their own. 10 minutes here, 10 minutes there. So you kind of give them their alone time, then you can do group activities. You really have to break it up so that they're not overstimulated. You always want to make sure when you are asking something of them or you're telling them that you give them very clear, concise directions. Robert, I need you to come over to my office over there on the right side of the room and sit in the blue chair so I can give you your medicine. That's exactly how you need to talk to them. If you feel like they are having some type of a delusion or they're having some type of hallucination, you want to ask them, Robert, what are you seeing? Do you see someone by you? Who is it? Do you hear something? What are they saying to you? Tell me what you're experiencing. You want you need to know what they're hearing and what they're seeing, especially if it's something frightening, like if it's somebody that's telling him to kill you or kill somebody else in the room. And sometimes it is thoughts like that. So you need to know what they're saying, what voices they're hearing. You do want to be empathetic to these patients. Like I said, these constant voices, these constant things that they see and hear can be very, very overwhelming for them and hard for them to deal with. You do not want to reinforce the hallucination. You do not want to say, oh yes, Robert, I see her sitting over there. She seems like a nice person. You do not want to reinforce that. You can just say, Robert, I'm really sorry that you are hearing these voices again. I know that this is very overwhelming for you. I can see that you're upset. And you don't ever want to challenge the patient. So you want to address the feeling. Robert, I can see that you're very upset that you see a woman who is telling you to do whatever, but I don't see that woman sitting there, but you seem very upset. Stay with the patient, especially if they're upset. You never want to leave them. You never want to abandon them, make them feel that way, or leave them alone. You can help the patient to identify certain triggers that if they're in an outpatient setting and you're with them every day, it's easier for you as the staff to help identify their triggers because you're with them every day and you see it. And then over time, you can maybe too much stimuli of those groups together causes them to have hallucinations. So maybe they don't do group activities. And then you can use distraction of simple activities such as drawing, puzzles, crafts, games, or even taking a walk. So if they say they see something, don't reinforce it, empathize with them, tell them that you don't see it, and then say, hey, do you want to go take a walk? Let's go outside in the garden and look at the flowers. Just try and distract them from it. If they are having delusions, you can avoid, so if they're saying that they're the president of the United States, you don't want to argue with them about it. Just listen to them, hear what they have to say. You can be very matter of fact with them when you're talking. You don't want to support the fact that they're of these delusions, but you don't want to challenge them either. You don't want to reinforce any of their delusional ideas. You want to help just reorient them to where they are. So if they say, my name's Robert and I'm the president of the United States and I have to go to a meeting, then you would just say, Robert, I need you to come over here because we're going to have lunch. You are at Mosaic right now and these are your friends. This is where we have lunch. We're going to have lunch. You can focus on underlying feelings. So you can empathize with them and say, you sound frightened. Kind of like how they seem to you, not so much the focus of the delusion, but how the patient appears to you. Obviously give them reassurance. And then the same thing with the hallucinations, we can try different distraction techniques to try and get them away from that thought process. All right, so these are the medications that we use. So our atypical second generation medications, this is your Abilify, your Safpris, your Resulti, clonazepam, iloperidone, Latuda, Zyprexa, Invega, Seroquel, Risperidol, and Ziprasidone or Geodon. These second generation atypical medications will target your positive and your negative symptoms. And they do have fewer motor side effects noted. The typicals, the first generation antipsychotics, that's your Thorazine, your Prolixin, your Haldol, and your Trilafon. These will only work with your positive symptoms only. So if your patient has positive and negative symptoms, they are not going to work, only for the positive symptoms. There is another class of medicine, they used to call them decanotes. They have a certain, they call them that because they have a certain chemical makeup that has like, they're like an oil-based type of a medication. These are usually used as long-acting injections. So these used to be called, you'll hear them a couple of different things in the clinical setting, decanotes, or they will call them depot injections. We usually see these used for maintenance therapy for patients. They come with your atypical medications and your typical medications. So this would be your Abilify, your Prolixin, your Haldol, your Zyprexa, your paliperidone, and your risperidone. So these are medications that last up to 2 to 4 weeks. They're very long acting after you give them. They're only injections only, and they go into a large muscle. So what gives them their long acting property is that they're oil based. So they're slower to be absorbed in the body. To draw them up, only to draw them up, you need to use a large bore needle, and then you would use just an intramuscular needle to administer them. Usually these medications are used for non-compliance. So where I work, if we have a patient that is acting out and we have to call what we call a BERT, which is a behavioral response team, where our nurses come from the psych unit and we have to restrain them, then we will give them, usually it's Haldol or Zyprexa that we give. I've seen it give risperidone given a couple times. But so these are used for non-compliant patients when we're trying to regain control of them. They're like a chemical restraint. So with our antipsychotics, we know that they do have, the typical and the atypical have general side effects that are common to both of them. So sedation makes them tired. We know that they have a lot of those anticholinergic effects, so dry mouth, constipation, blurred vision, urinary retention, and then orthostatic hypotension. We know that some of these medications cause weight gain. So for those patients, you know, the big problem with these medications is that because they cause these unpleasant side effects, people are not persistent with them. They don't keep taking them because they don't like these unpleasant side effects. So more often than not, some of these will just go away on their own the longer the patient takes the medicine. Sometimes they don't. So this is why we have such an issue with non-compliance. So for our patients that have weight gain, we want to make sure that we are telling them that they should eat a balanced diet, help control their portions, engage in some type of regular exercise, and focus on minimizing the gain. Some medicines cause photosensitivity. So for those patients, we want to teach them to avoid sun exposure when they go out. We want them to make sure that they're wearing protective clothing and sunscreen when they are in the sun. They might have a decreased seizure threshold. So if they normally suffer from seizures, it might be that they have to up their seizure medication because that threshold is now lower and they're at risk for having more seizures. Galactorrhea, which is a milky nipple discharge that is unrelated to being pregnant and having like a normal milk production if you just had a baby. And then amenorrhea, which is absence of menstruation. And then there's always sexual dysfunction as well. So some of these are not very pleasant side effects, and you could see why patients would not be compliant with taking the medication. And then we know that with clozapine, they are at risk for developing agranulocytosis, which is very rare, but it can happen with clozapine, and this can be a fatal side effect. This is the failure of the patient's bone marrow to produce the adequate amount of white blood cells necessary to be able to fight off an infection. So usually if your patient is on clozapine and they develop a fever, or they complain of malaise or a sore throat, and then a low white blood cell count, you would want to try and look into that because they could be developing agranulocytosis. All right, so when we talk about our atypical side effects, these are the anticholinergic symptoms. Dry mouth, we can tell our patients to use ice chips or even hard candy that can help keep their mouth moist. If they complain of blurred vision, we would have to assess that. So we can we would want to probably report this actually to the physician if it doesn't improve. So if they've had if they report blurred vision that was just a very quick onset, like it just happened 4 days after taking the medication, and if they've had a recent eye exam and it doesn't improve within like 2 or 3 weeks, then it's something that you would want to report to the physician. Constipation, this is something we can control, so we want to educate them about increasing their fluid intake, their dietary fiber. We might have to give them a stool softener. Urinary retention, so we would want to just educate them about any hesitancy to go, burning or pain when they go. And then this is one of those things, again, that could improve within a couple weeks, but if it doesn't, or if it's severe enough, obviously we would want to tell the physician. And then orthostatic hypotension, so really educating these patients about getting up slowly, sitting on the side of the bed for a minute, and waiting to get up until they don't feel dizzy or lightheaded anymore. And then we know those other side effects that we may see, those extrapyramidal system side effects. So these are the reversible. So remember, these are reversible movement disorders that are induced by some type of neuroleptic medication. So we could see acute dystonic reaction, akathisia, or Parkinson's syndrome or drug-induced Parkinsonism. All three of those fall under our extrapyramidal system side effects. All of these are reversible. So if your patient suffers from acute dystonic reaction, this will usually begin within 48 hours after beginning the medication, or it could, even if they've tolerated their normal dose, but we increase their dose, we could still see this. The patient will present with acute and painful muscle spasm of the tongue, the throat, the face, the jaw, the neck, and the back. Symptoms may include a severe upward deviation of their eyeballs. We call that an oculogeric crisis, or neck muscle contraction that pulls that neck to one side, torticollis. It's accompanied by the protrusion of the tongue. They may also have dysphagia and laryngeal and pharyngeal spasms. So this, if they have that, can actually compromise their airway, and this would absolutely be a medical emergency. They might report difficulty swallowing because of that protrusion of the tongue or those laryngeal spasms. It is extremely frightening to the client and anyone that is around them that sees this. It's also very painful. But if we do think our patient has this, we can give them Benadryl, either intramuscularly or intravenously. If they're having this reaction, I would say in the hospital, they're going to get it IV, because we want to kind of reverse this pretty quickly, especially if their airway is compromised. Or we can also give them Cogentin, and that is given intramuscularly. So akathisia, this is the second type of side effect that we can see. This occurs after 3 or more weeks. So this is a little bit different than that acute dystonic reaction, which usually occurs within 48 hours. So 3 or more weeks from the start of medication, or an increase of the dose. It's described as an inner restlessness. They might be pacing around. They won't be able to sit still in the chair. They may even be irritable because they feel like something just isn't right inside. They just feel like their insides are just shaky, and that they just feel like they don't have any control over themselves, and they might appear tense. It causes their legs and arms to move, so they might do foot tapping, pacing, rocking back and forth. They just won't be able to sit still. Patients will describe it as being very uncomfortable. Sometimes it can be misinterpreted as just agitation or anxiety. Unrecognized severe akathisia can result in patients committing suicide. So this is really important for us to be able to recognize. Early detection and successful treatment of EPS is important because we want to promote the patient's compliance with medication. So for this, we could treat also with the Cogentin or the Benadryl, and then another medicine too called Artane. And then the Parkinsonian syndrome or drug-induced Parkinsonism. So this, just like the akathisia, occurs after 3 or more weeks of a new medication beginning or a change in their dose. Their symptoms are going to be very, very similar to Parkinson's disease. So they're going to be drooling. They're going to have a tremor, usually a fine tremor of the hands and or of the feet, and they do like this pill rolling with their finger. Muscle rigidity, which can be identified by doing a check for cogwheel. That's in your book. You guys can look that up. They're going to have a lack of spontaneous arm swing when they walk. So their arms will be stiff at their side. Difficulty initiating movement. So it's hard to get them out of the chair and hard for them to take that first step. Bradykinesia, which is a slowed and less effective movement. So these patients move very slow and they have like a shuffling, they kind of like hunch over and they have like a shuffling gait. They don't always pick their feet up off the floor. And they can also suffer from facial masking, which can look like they just have a flat affect all the time. So now we have some irreversible side effects. So this is not irreversible. This is tardive dyskinesia. So this is described as slight involuntary muscle contractions of the mouth, the tongue, and the face. These patients look like they're smacking their lips together or they're chewing something in their mouth. It becomes progressively more severe and they may develop jerking or snake-like movements. Not very painful at all, develops gradually over a course of time. So usually 6 months after they started taking medication into their second year of being on that medication. And it is usually irreversible. All right, let's see. I do have a couple little videos to show you. Oh. Did it come up? Oh, hold on. Let me, now I got to figure out how to share it.
But his dystonic reaction involved his spinal musculature, his leg, and interestingly was asymmetric. That's one of the many things about acute dystonia we don't understand. Since your brain is presumably symmetric, why should this sometimes involve one part and not the other? And sometimes it may jump from one side to the other side. Why should it spare one place and not the other? Here he's trying to walk, and you can see the severe torticollis. Okay, now turn around and look at me. Is your neck twisted? Mm-hmm. Just stay like that. Just stay right there. Look at his tongue. That's involuntary that his tongue is stuck out.
I twist it back.
Can you overcome it if you take your hand and push on your chin? We're asking him at this point whether he has what we call a geste antagoniste. Patients with dystonia frequently are able to overcome the dystonia just with mild touching. They're not really pushing their heads over.
Oh, hey, they heard it talk a lot. This is great.
In the emergency rooms, it's the nurses who see most of these things, and they're easily recognized. So you see a patient who comes in who's just received Haldol, and their eyes are up like this, and you talk to them, and as they're talking to you, their eyes come down, and then they drift back up again, and they look like this. If you've never seen that before and hadn't read about it, the first thought, I think, has got to be that this is part of their psychosis, in which case, of course, you may be tempted to treat it with more drug that caused it in the first place. So I think the main differential there is psychogenic.
And then in about 2-3 minutes, you'll be all better. Okay?
Okay.
Okay. Try not to jump. It doesn't hurt much to go in.
So they'll have a flurry episodes of these things until they're given intravenous diphenhydramine or intravenous benztropine or diazepam, and they go away within a few minutes of getting the drug. And you feel normal?
Not all the way.
And they're virtually 100% curable with these drugs.
9, 10.
And in what way are you not normal?
I still feel pain in my neck. That's it.
Okay, but that's it.
Like it's really stiff.
So he was treated with Benadryl, diphenhydramine, and it went away. And he got put on Benadryl for a few days, and it never came back. Can you open your mouth? Close it again. Can you tell me what you're experiencing right now?
I'm anxious. I can stop my legs if I concentrate.
Can you describe, do you feel any uncomfortable sensation in your legs?
It's only uncomfortable, it's not painful.
It's uncomfortable.
Yes.
Can you use any descriptive terms for people, who are looking at this? Do you feel restless?
Yes, I feel restless.
Do you get relief by moving around?
Yes.
Now, could you stand and not move?
I can try.
Okay. Oh,
I'm standing on one leg.
that makes it easier, huh?
Yes.
Are you moving your toes inside your shoes?
Yes.
Okay. On a scale of 1 to 10,
I'm going to fast forward it to the Parkinsonism so you guys can see that.
The things that I think get missed most in the psychiatric population are the slowness and the change in their walking and their posture. Most schizophrenic patients who are treated with neuroleptics don't have significant walking problems or balance problems, even though you may see that they're a little bit stooped and they don't swing their arms so much. Try not to lose your balance. And they may be a little slow, but it doesn't really interfere with their activities all that much. But I'm going to do it harder. And in a sense, you can understand it. If their psychosis is under control and the patient's not complaining about something, terrific. Leave well enough alone. Why rock the boat? But I think there's a lot of Parkinsonism that goes on that's just not recognized. Or if it is recognized, people say, well, that's the price you have to pay in order to get adequate psychosis control. Do you ever have tremors? Do you ever notice that you shake?
Yes. My thighs shake a lot, and my fingers shake a lot.
Okay, does that bother you much? The other problem is that they're often not able to supply history.
A little bit.
They often tolerate drug side effects because they've lived with them for 20 or 30 years. And I think they probably just shrug their shoulders and say, this is part of what's wrong with me.
Mm-hmm.
Plus, they've been treated for so long.
See her delayed reactions when she asks something?
Of these things. You had 2 left feet.
When they made that last parade in front of the generals and admirals, and I wasn't there.
Okay. And you think that was because your psychiatric problems were beginning then?
Yeah, because the marching, I couldn't march.
You couldn't march because of 2 left feet. What does that have to do with any mental illness?
The feet connected to the knee bone. The knee bone connected to the thigh bone.
And that's all connected to your brain. Is that right? I see. Okay.
Tardive dyskinesia.
He doesn't really have a bad case of it. I have one more just quick little thing I want to show you guys. You can read these. These are just some good clips that I found that showed good examples of it, but I will.
Professor Davis, can you let Raven in, please?
Yes. Okay.
Wow, look at this. This feels so natural and...
Try not to be distracted by the movements in her lower face. Please focus your attention on her eyebrows.
Yep, that's tardive dyskinesia. And that is not reversible.
In the second segment, notice this patient's blinking. Try not to be distracted by the other facial movements. Notice the blinking takes place during the finger tapping exercise. This is one of the activated movements. The 1-point score reduction used by some examiners is not recommended. The score on the screen does not include any such reduction.
See the
The
movement with
second
her
body
tongue?
area to be scored upon completion of the Ames examination is that of the lips and perioral area. The examiner is looking for evidence of puckering, pouting, and smacking.
Okay. All right, I'm not gonna keep you guys showing you all these videos. I put them on the PowerPoint. If you guys, I put one for acute dystonia, one for that one we just saw, and then one for drug-induced Parkinsonism. So you guys can look at those. All right, so neuroleptic malignant syndrome. So this is a very, very dangerous side effect. Always starts with the patient developing a fever. Once they develop this fever, it will progress very quickly. They will have diaphoresis, they're going to have hypertension, elevated pulse, cardiac irregularities, so, tachycardia, bradycardia, irregular heart rhythm. They're going to have muscle rigidity, so they're going to be very tight, incontinence. They might even be unconscious, and then eventually it's going to lead to coma or death. If we run labs on these people, there is a muscle enzyme that's going to be elevated. It's our creatinine phosphokinase, which is also just called CPK. In their labs, you will also see leukocytosis, so just a very few white blood cell count, if any. So the treatment is obviously we are going to stop their antipsychotic medication immediately. We're going to make sure that we have IV access because we're going to give them fluids and electrolytes. We know that they're going to be having this severe diaphoresis, so we want, and this fever, cooling blankets if necessary. If they have them where you work, they're probably going to get some cardiac meds to deal with whatever cardiac symptoms they have. And then we're obviously going to give them some antihypertensive meds to help control that hypertension. So what type of interventions do we do with these patients? So they need a lot of therapy, individual and group, depending on how severe their case is. We're going to give them supportive care. We want to support them, encourage them. We want to give them medication to help. So those antipsychotics, we want them to be able to manage their medication, and we want them to stay on this medication because we want the best possible outcome for them. So they need a lot of education, and they need a lot of monitoring of their symptoms. And then we want them to have access to a lot of community supports because these patients don't live in the hospital. Like any other mental illness, they only come in the hospital if they're having such like a big exacerbation. They tried to commit suicide or they were having some type of a crisis. After that's resolved, we put them back in the community again. So they need a lot of community support. So maybe they're going to live in a group home if they can't live on their own. They're going to have daycare, care centers during the day where they go, where they can do things and work on their activities of daily living, learn how to cook, learn how to manage a checkbook, things like that. You want to give the client an opportunity for social contact. So you want them to be able to feel better about themselves. You want to increase their self-esteem, their self-confidence. You want them to be able to build meaningful relationships with other people so that they have a bigger support network. We also offer social skills and training. So they do offer something that's called cognitive adaptation training. This was designed to help improve them to be able to adapt in their home setting. So just accomplishing those activities of daily living. If they're in a group home, being able to participate with other members of the group to accomplish things in the house. There's something called cognitive enhancement therapy. This will combine a computer-based cognitive training with group sessions with other patients that allows them to practice and implement their learned social skills. These were designed to remediate or improve the client's social and neurocognitive deficits, such as being able to pay attention, such as remembering things, being able to process information that they're told. All of these things will help improve their capability of being able to live in a community setting and be successful without having a lot of crises and needing that inpatient therapy. Family therapy, obviously, this is designed for the patient and their family to help educate them, to help diminish some of those negative effects that we know, those stereotypes that come around these mental health diseases. And then if the family understands the patient and they are trained to support the patient in the right way, it's obviously going to help reduce that rate of having a relapse. Family education, we just said that. And then family members also need a supportive environment. This is a big deal to be able to take care of someone that has a mental illness to this magnitude. It can be very draining. So they can suffer from caregiver strain. They might be suffering from financial issues. Maybe they can't go to work every day because they can't leave this person, their child, home by themselves because they can't make good decisions for themselves. They might hurt themselves. So maybe they're suffering financially. Maybe there's no daycare to send the person to during the day. Maybe it's putting a strain on their marriage. Things like this do cause strains on everyone's relationship. So there's a lot of components to this. And then when we're evaluating our patients, then these are some of the things that we want to see. We want them to state that the voices are no longer interfering with day-to-day tasks. So being able to get rid of these voices altogether might not be an option for some people. So they have to learn to live with them. So as they go through treatment, they'll realize, you know, this is just another hallucination, that these people aren't really here. And they're going to work on ways to find out that, to minimize the effect that they have on them so that they can still function in their day-to-day interactions. They will say that their delusions no longer interfere with their ability to function in their family, in their social or their work situations. Patients will engage in pre-crisis level of self-care. So we would like to get these patients to the point where they can recognize that a crisis is coming on. We said earlier that we want them to be able to identify triggers that cause, you know, hallucinations and delusions. The same thing with crisis. So we expect them, it's not always going to happen, but that's our goal. Patients use appropriate social skills in their interactions, and then patients will demonstrate decreased suspicious behaviors when interacting with others. All right, so when these patients live in the community, sometimes they live in, like I've been talking about, these group homes where they live with 8 to 10 or 12 other people who suffer from probably the same mental disability that they do. That will be their full-time home. They will have visitation from their family members and their loved ones at scheduled times. Or if they're high functioning and their medications are working, they can actually live independently. They do offer behavioral home health care. So they will have healthcare services that will come to their home, it will come to the group home, and it will work with them on different behavioral strategies. There's a lot of community support programs like these daycare centers and these outpatient day centers where they can go. The bus will come to the group home and pick them up. They'll take them there they'll have breakfast, lunch, and dinner. They'll send them home at 5 o'clock, and then they go back to their home or their group home. A lot of these patients don't drive, so that's why they need, you know, support within the community from different programs. And then case management services often include helping that client with housing, so finding housing for them that's appropriate for them, independent housing if that's what they need, or housing that has more security and more supervision if that's what's appropriate for them. Transportation, so we want to give them transportation so that they can get to the store, so they can go to the bank, so they can engage in things that contribute to them being able to live independently. Money management, they can offer services that help them set up a checking account, show them how to manage it, and that will come and check on them twice a month and help them manage their checkbook. And then someone who will keep a log of all their appointments and make sure that they get to their appointments when they're supposed to. And there's also recreation. They'll plan like different trips to, they might go to like a buffet and have lunch one day, or they might take a little bus trip to New York City or something like that with their case managers and the people that they live with. So community-based care, the goal is for patient recovery. So for the chronically mentally ill, we want them, are they ever going to be in complete recovery? Probably not, but we want them to learn how to function in that community. We want them to live their best life. We want them to, what's the word? We want them to participate in various activities in their group home and outside of that area. We want them to really engage in the programs, what they have to offer. We want to teach them life skills. We want to also provide support for family and caregivers because they really need it. And then if possible, if they are, if it's appropriate for them, we want to teach them vocational skills so they can learn to live independently and be successful. So mental health promotion always goes beyond just controlling those symptoms and managing their medication. That is just a very small part of it. They need a lot of intense one-on-one or group therapy. They're going to have to manage this illness for the rest of their life, so they need to be equipped to do so. We need to teach them how to manage their own lives. We want them to make effective, safe decisions about their treatment and their life, and we want them to have an improved quality of life. We want to foster them to be self-efficient. We want to empower them to take control over their life and make decisions about important things in their life, like where they want to live, where do they want to work. We want to improve the client's resiliency and their ability to bounce back from any kind of emotional or stressful event, because we don't want it to throw them into a crisis. So we want to teach them how to be resilient. We want to give them those coping skills. And then we want to improve the client's ability to cope with the problems, stress, and strains of everyday life. So we know early intervention, we want to recognize these things as soon as possible. We want to make sure that we're accurately identifying those patients who are at risk. We want to improve their prodromal symptoms. So these are considered their sleeping difficulties, any changes in appetite that they have, if they report a loss of energy or interest, any kind of odd speech that they have, are they hearing voices? Are they exhibiting any type of peculiar behavior? Are they making inappropriate expressions of their feelings? That paucity of their speech, their ideas of reference, and the feelings of unreality. So these are things that we need to look for, and that actually, I mean, most of us, if you're not in nursing school or you don't work in this field, these are not things that would probably signal that there's something wrong with your child. Maybe the peculiar behavior, but maybe not nowadays. People just have the feeling, hey, let my son or daughter express themselves. And so that might not even be a trigger for them. So you can see why this goes unmanaged and unnoticed for a while, because some of these symptoms can be pretty vague. And then we want to prevent social stagnation or decline, because we need them to have a good social network. And then prevention or delay of progression to psychosis. And then lastly, self-awareness. It can be a challenge when the patient is suspicious or mistrustful, or the nurse feels frightened. And it would be easy to feel frightened in that situation. So you want to acknowledge the feelings. If you're with a patient and you all of a sudden feel unsafe, or you think that he's acting strange, acknowledge those feelings and take measures to make sure that you are safe and the patient is safe as well. Don't be frustrated if the patient is non-compliant. This is no different than your patient that's not taking their blood pressure medication, that keeps coming and being admitted into the hospital for high blood pressure. It's just that that's a physical issue. This is a mental issue. So you cannot be frustrated if they don't do what they're supposed to do, and don't take their success or a failure personally. We are not responsible for the success or failures of our treatment efforts. Patient strengths, if a patient comes in for a crisis, or in the outpatient setting as well, you always want to make sure that when you are talking about things that you want to improve, you always want to focus on their strengths as well. The negatives are always taken a little bit better if you say some really good things at first. So always acknowledge what their strengths are. And then if they're in the hospital, if they're having a crisis, make sure that you talk about the times that they've lived outside of the hospital. Like maybe they haven't had a crisis for the last 6 months. Make sure you note that. Hey, look, it's been 6 months since you've been here. You're really doing well on the outside. This was just a small setback. So try to focus on the positive. No nurse ever has all the answers. We're always learning and growing. So it is completely okay for you to look to your colleagues for support and discussion of any type of self-awareness issues that you have. All right. Any questions?
Yes.
I have a question.
Okay.